We're really, really excited to have this panel here today. The behavioral health workforce plays such a significant role in many of the themes that we've been talking about: how to improve the delivery system, how to improve care to people across the lifespan. And we're really lucky to have a panel here today that is going to help us understand some of the current issues and forward-facing issues that we need to be thinking about when it comes to behavioral health, which of course has been quite a bit in the news of the last few years with the opioid epidemic, with many efforts to improve behavioral health policy. But we're really excited here to talk about the workforce. So I'm going to go ahead and introduce our panel. First, to my left is Peter Maramaldi, who is a professor and a director of the PhD program at the Simmons School of Social Work in Boston. He's also an adjunct professor at the Harvard T.H. Chan School of Public Health in Social and Behavioral Sciences, as well as an instructor at the Harvard School of Dental Medicine in Oral Health Policy and Epidemiology. So you get both of those important and often neglected body parts, I guess you could say. Thanks for being here. Next, we have Andrew Sperling, who is the Director of Federal Legislative Advocacy for NAMI, the National Alliance on Mental Illness, where he leads NAMI's legislative advocacy initiatives in Congress and before federal agencies. And finally, I'm very pleased to introduce Mohini Venkatesh, who is Vice President of Business and Strategy at the National Council for Behavioral Health, where she leads the council's efforts to create new partnerships to support community behavioral health. So welcome, everybody. And I'm just going to ask, I know there were a couple of problems hearing in the last panel, so if anyone is having a problem hearing at any point, just kind of raise your hand and we'll kind of keep an eye out for you so that we can make sure everybody hears the conversation. So let me dive right in to the first question, and let me kind of ask a broad question, which is, how do you see the role of the behavioral health workforce changing, for better or for worse? And you can put whatever time span you want on it, but how do you see the behavioral health workforce changing at this moment in time?
Shall I start?
Sure.
There's a physician in Boston who was struggling trying to help immigrant populations and just didn't know what to do, spending too much time doing non-medical things with this whole population. So brought in somebody who would help with the non-medical stuff. And that person was Ida Cannon, and the physician was Richard Cabot, and the year was 1915. So here we are, we haven't gotten very far, because we're really dealing with the same things. When you said time frame, it made me think of that, Sarah. Mm-hmm. But I think where we are with behavioral health, and I won't belabor it because I know my esteemed colleagues here have a lot to say, is that if you look at historically, in 1965, Medicare brought people into the hospitals who had never had access to medical care before, and they came in very ill, and they came in somewhat older than one would expect. And it just drove up costs. And we saw a real surge in social work. And social work at that time was at a salary level higher than nursing, RN nursing. And then right straight through till 1980, and this is the policies always driving the behavioral health workforce. When nursing took over the discharge planning, which brought the costs down for the hospital stays, nursing and social work switched salaries in effect, and it's remained constant ever since 1980. But I think that we see now an opportunity for the behavioral workforce with the Affordable Care Act and the emphasis on team. And I think that I'm working on several studies now. We travel around the country, and everybody's talking about team, and everybody's talking about behavioral health, and people using the term coach, navigator, and I think that we don't really understand what social work is and what social work does, but we've been doing it for 100 years, and I think that we're beginning to bring it forward. And the way we're doing that is through, and you mentioned the PhD program, is we didn't used to have our own PhDs. We're developing a new technology in our own field. And we have with us today Darla Spence-Coffey, who's the president of the Council on Social Work Education. And I think Darla has done a terrific job, and she's gotten social work recognized in IPEC. And we're beginning to bring behavioral change theories, evidence-based theories, to an applied practice model where we can help people change their behaviors. And if you think about the patient contributions to illness and the patient contributions and complications and the strains on the healthcare system, it's a terrific place to enter. So the short answer to your question is it's a real opportunity right now.
Thanks. Anyone else want to weigh in?
Sure. Integration is the name of the game right now, and it's something that comes up in a variety of domains when we're talking about changes happening in healthcare, particularly with the behavioral health workforce. What we're finding is that there are immense opportunities for the behavioral health workforce to participate and engage in conversations about physical health, both thinking through prevention, certainly early identification, but also treatment. The challenge here, however, is this workforce, does it have the skills and the training to be able to do that? And secondarily, is the system set up to support it? And really the challenge that we're experiencing state by state is that the behavioral health workforce, while there is immense amount of commitment to screening physical health issues, assessing people's blood pressure and weight and sugar, et cetera, they oftentimes exist in health organizations and in states and communities that don't give them the time to be able to do that with each and every patient that they see, put that down in the electronic record, if they have an electronic record, and then make sure that that information is acted upon by the healthcare workforce, whether that's in the specialty behavioral health organization, whether it's in a social service organization somewhere in the community, or in more sort of acute or primary care settings.
So we still face enormous workforce challenges in the behavioral health world. I'm going to talk about integration in a second, but I also want to note the fact we, at least in the Medicare program, we have historic vestiges that are actually continue to plague that workforce challenge. And let me give you one example. Up until 2014, in the Medicare Part B program, the participation rate of psychiatrists was the lowest of any specialty organization. And the reason for that is because we had a discriminatory 50% copay in the Medicare Part B program. So unlike a primary care doctor where the copay is 20%, I'm looking over at Mark because he was a part of this legislation that would pass the Finance Committee, we had a 50% copay for a psychiatrist. So a psychiatrist was left with the responsibility of finding their patient and chasing them down for a 50% copay.
Part of fixing it.
Yeah, exactly. Part of fixing it, absolutely. And we finally got that done in 2014. The legislation passed in 2008. It was phased in. But the point here is that oftentimes the workforce challenges, at least we feel as patients, is not being able to find a psychiatrist willing to take Medicare, not being able to find a psychiatrist that's participating in your particular plan. So we continue to have that significant problem with a number of systems. On integration, I just want to note, we need to move down this road. We are moving down this road, but it needs to be bilateral. And what I mean by that is the way we integrate care for someone who has arthritis or heart disease and never had an episode of depression until they got into their mid-50s is very, very different than someone who had their onset of schizophrenia when they were 18, 19 years old. And now here they are 20 years later, and because of pathologies around high consumption rate of tobacco, sedentary lifestyle, poor diet, on and on and on, they've suddenly got diabetes and heart disease when they're 45 years old. What the strategy for those two individuals is very, very different. That individual who's never had a behavioral health problem until they reach their mid-50s, referring them out to the specialty behavioral health system is a really bad idea. They don't want to be told that they've got depression or they're quote, mentally ill. And we need to get those behavioral health services in the setting that they're most comfortable, the primary care doctor, the endocrinologist, et cetera. And it's exactly the opposite for that non-elderly adult with schizophrenia with 3 comorbid chronic medical conditions. The primary care system does a pretty poor job of serving them. We need to bring those primary care services into the specialty behavioral health setting. So it's a bilateral strategy we have to undertake.
Thank you. So I'm hearing this theme of, sort of past is prologue, and it's hard to talk about the future of behavioral health unless you talk about the past and the history. And I wonder if, any of you can comment on that, to what extent, are we still kind of climbing out of this, the historical kind of separation and segregation of mental health and behavioral health, which of course includes addiction, substance abuse treatment, and physical health, and this notion that they should be separate, and now the struggle to integrate them. If you could comment on kind of where are we along that trajectory?
Absolutely. We have much work to do to break down the silos. One of my best friends, I grew up in Massachusetts, and one of my best friends still lives there and is a primary care doc at an FQHC near my hometown. And every time I visit with her, she talks to me about her exasperation. She's very aware of the behavioral health conditions that are going on in her patient population, very aware of the influence of trauma in her patient's experience with accessing treatment. She doesn't know what to do with that awareness. So there is a lot of stress and pressure in her FQHC around this idea of, well, let's go ahead and screen so we can start to identify where does this person sit on the depression continuum if they are struggling with depression. Let's assess what really traumas they've experienced and think through how do we integrate to a sensitivity to that into this person's treatment. But if you screen, if someone needs some extra help for an addiction, that they're struggling with alcohol or with cannabis, et cetera, or if they're struggling with depression, what do you do after that? Are there proper referral and connection to a specialty behavioral health, perhaps integrated into the FQHC? Is that actually in place there? And unfortunately, in her situation, it is not. Similarly, she provides services in an ER that's in a hospital near where I grew up. It is a complete mess. The amount of the folks that are coming into the ERs who are struggling with behavioral health issues, sometimes they come in and they say, my heart is racing, and people think that they're having a panic attack. Lo and behold, they have a variety of underlying chronic health issues, and they're really stressed about coming into an ER because they've had negative experiences of accessing care. It puts the workforce, whether it's you want to call it specialty behavioral health or general healthcare workforce, it puts an immense amount of pressure on them to be community problem solvers when they're not resourced to do so. When we look at sort of undergrad and graduate programs and think through what really are the curricula that is being offered, and is it promoting this philosophy of integration? Are there courses that are expressing that philosophy and then providing tangible examples of how you make this a reality every day? It's another great example of we have a long way to go before we're sort of setting up the workforce to succeed with this mindset.
I don't know if we'll ever totally break down the silos and not have a specialty behavioral health, not have a system of community mental health centers, and not have inpatient facilities that only do behavioral health. I don't think we're ever going to get there, and I don't think that's probably, it should be a realistic goal. And we at NAMI talk about our public mental health system as our system, and it's what we have, it's what we know. We don't want to see it go away, and that's a big concern that we would articulate that as a goal and try and get there and feel that we failed just because we didn't get there when there's so many things in the interim we can be doing to better integrate care and deal with what really the horrific story for the population I represent, which is early mortality. And it's not from their underlying psychiatric disorder, it's poorly managed diabetes, poorly managed heart disease, COPD, and an adult with schizophrenia in the United States has a life expectancy that hovers right around an adult in Bangladesh. I mean, it's a national disgrace, we've got to deal with it. But with the expectation we're going to do away with the specialty behavioral health sector and we'll get complete integration, nirvana someday, is not a realistic goal. We ought to be focusing on early mortality issues like that and improving access to primary medical care services for the population with severe and persistent mental illness.
I'm more hopeful. And I think if nothing else, private equity is going to force our hand.
Yeah.
The same way they forced our hand on the way we deliver health care, they're going to force our hand on being more efficient in the way we deliver health care. And those efficiencies will come by having everyone work to the top of their license. For the past 15 years, I've been teaching a course at the Harvard Medical School on interdisciplinary collaboration. And it's very simple. We talk about primary, secondary, and tertiary competencies. And I spend a lot of time with students, and they're bright-eyed, and they're excited, and they really want to go out there and do it, and they love what they're doing. On the other side, I spend a lot of time traveling around the country interviewing physicians, nurses, and social workers. And it just saddens me every time every physician I interview, I say, what do you love about your job? And there's usually a silence. But if I say, what are the challenges in your job? They attack the electronic health record, third-party payers, they go through the list. They can't do what they want to do. We talk about burnout. But there's hope for the future where now we see these models, and there's a guy in Boston, Marty Solomon, he's an early adopter. And we have behavioral theories about implementing change that we don't use in medicine, we use those in industry. I did a patient safety study, and we went to the airline industry and used their technology to see how we could promote patient safety in dental medicine. It's pretty astounding to see how far behind we were relative to people who put planes in the air. It's just the same thing. We're dealing with people's life and death issues, mortality issues. But I do think that there is hope for the future. And you know, if we want to point the fingers, I mean, you go into I'm an academic. I mean, I joke at faculty meetings and I say, we're trying to change the curriculum. Hey, look out the window. A glacier just zoomed by relative to the speed with which we're willing to change things. But our hand is being forced. And I think that's the hope.
Thanks. So let's talk a little more about this question of access, and, you know, where are we with access? You know, and I'm like almost afraid to ask that question, right? But, you know, Andrew, you mentioned a specific example of people who have severe persistent mental illness having access to the appropriate primary care and other kinds of services. What about access, you know, what about access to behavioral health services for the various populations who might need those services? And what can we do to improve it?
So I'll just briefly note, it varies across the spectrum. So at least for an individual with severe mental illness, they are likely to be able to easily access services from one of Mohini's organization's members, right? A publicly chartered community mental health center that's legally obligated to serve that particular targeted population. I think when we run into other problems are people on the more mild end of the spectrum who have that poorly managed depression, and because of that underlying anxiety depression, are not able to effectively manage their arthritis or their heart disease or their underlying serious medical condition. And I don't think we should have the expectation that especially behavioral health settings are going to be able to serve them. It's about getting behavioral health services to them in a primary care setting. And recognize this is already happening. I mean, 69% of the prescriptions that are written for antidepressants in this country are by primary care doctors, endocrinologists, OBGYNs. So many of them are doing already, and they're not necessarily doing it well, right? An OBGYN who's got that 10-minute, 15-minute visit with their patient and can see there's something wrong here about, you know, the fact that, you know, it was a struggle for his patient to get there because they can barely get out of bed. Their depression's so bad. That underlying medical condition is not going to get better until you deal with that depression. And there's more that we can be doing to bring specialty behavioral health care into primary care settings.
So is the question, is there a question of training more healthcare professionals in behavioral health specifically, kind of to specialize in it, or, you know, Mohini, you raised the example of a person who's in the primary care setting and just doesn't know what to do once the patient is screened. So are we completely missing an opportunity to train kind of the larger cadre of the healthcare workforce in basically what to do and how to help heal people who have behavioral health needs?
Given the prevalence, particularly if you think of mental health and substance use issues in the broadest form, mild, moderate, and severe, given the prevalence of these issues, it's incumbent upon us to not pick and choose strategies here and to think really as inclusively as possible, because we all are connected to people that we love and care about that have struggles with mental health and substance use. So thinking through, you know, people being trained in sort of general healthcare settings, helping them with the knowledge and the skills that they need to recognize the early signs and symptoms of mental health and substance use issues would be great. And then also thinking through, you know, when I was in graduate school, and I have a lot of friends who are doctors and nurses and all of that, I didn't even know what community behavioral health was. I didn't know that there was a core of safety net providers that are treating folks who have multiple comorbidities, have a severe and persistent mental illness, and if they were able to get some community-based services, access to medications that they need, that they could live in community and achieve the goals that we all want for our lives. I had no idea. I just thought that you would put them in the hospital somewhere because there was no other option available. So, for us to be offering some training and guidance in graduate programs that are specific to behavioral health, that, hey, there is this place that you can go work where you can test out your skills and reach some of the folks that need it the most.
You want to comment?
I do, actually. I think that it really, if we think about the competencies that we're training students in, do they match the competencies of the practitioners that they're going to go out and work with in their practices? What are the competencies in practice? Do we, we do continuing ed, but do we really measure those competencies, and how do we really adjust those competencies right through the course of one's career? And I think that the real opportunities in terms of getting access to behavioral health are, again, the efficiencies. How many physicians are really not working the majority of their day? What percentage are they working in their primary competencies? How often are they doing secondary or tertiary competencies, things that somebody else could be doing? And do they really want to do those things? We talked earlier today about the electronic health record. I interview so many physicians that say, I get so much, I don't read it, I just sign off. And they say, yeah, it's one, because I'm all a proponent of electronic health records. And they say, yeah, it's wonderful. Who's got time to read it? And then there's the notion of, I think the other opportunity that we're beginning to see in a lot of innovative programs is this emergence of team. Now, team means so many different things to so many different people. It's kind of the same. You walk around healthcare and you say team, it's like walking through the supermarket and see the word natural on the food. I mean, it means so many different things to so many different people. But there's some, I've visited some programs, I read about a lot of programs, and it really comes down to the common core is this huddle in the morning, whatever you want to call it. Some carved out time of day, billable time of the day, when people sit down and communicate with each other. And there's an opportunity to identify those efficiencies either through screening instruments, who we're going to refer people to, and that's where I think that there's a real opportunity, not only to improve the health and the efficiency of the team delivering care, but the recipients of care get a more direct access, more direct route to what they need, rather than what our organization is able to spit out.
And we're going to get there. If bundle payments work the way they're supposed to, and we're going to start paying for value rather than volume, the system's got to get there. Because the cardiologist is going to get dinged because the bad outcome on the cardiac side, because that patient is not motivated to engage in treatment and do all the things they're supposed to be doing to deal with their heart disease because they've got underlying depression. If we realign the incentives right, it's going to happen.
So we talked a lot in the last panel about burnout and this idea of, burnout and overwhelm, and talk about the role of the behavioral health professional in a team, and can that help to reduce burnout on both ends? And I assume burnout is also a problem in the behavioral health workforce, just as much as the workforce we were talking about on the last panel. So are there some good examples of models that have been used that can help to improve not just teamwork and kind of information exchange, but also morale and joy in work, if you will?
I'd love to know what those things are if they exist. But I'm going to offer a slight twist in my response and talk a little bit about the role of technology in all this and the potential that it creates. There are some incredible apps and tools that are being piloted around the country, helping to think through patient activation, sharing of information from the patient to the provider in between visits, helping mobile outreach teams stay connected to their patient population wherever they are in the community, helping teams to communicate with each other so much more. The stuff, it's really difficult to make it sort of align with the workflow in different kinds of settings. we have a long way to go with that. But on a more positive note, offers some incredible potential. You know, all of us in our jobs, we don't want to have to, if we've just spent 8 hours in my car driving around connecting with my patients in the community, I don't want to have to go back to the office to type up notes. I want to be able to do that in my car quickly and then go home at night to spend time with my family. Or if, you know, if my patient misses an appointment several times, I want to know what's going on with them, and not knowing that challenges sort of my aspirations and my hope that I have that I'm having an impact on the patients that I work with. So opportunities to help providers stay connected to patients, to stay connected to their colleagues, can help to reduce sort of fatigue and exhaustion, and a sense that, you know, you're trying, but not having an impact. These things can really help to shed a light and help us to understand the impact we're having day to day on patients, which I think for all of us would be something that we would want, to know that we're making a difference.
I'm working on a study now with Karen Donnell at MGH on frail elders living in the community, health teams' delivery of services. And every place we go, it's a national study, every place we go, people say, I wish I had a social worker in my practice. I'm not sure they know what they mean when they say social worker, but if they knew what they meant, and we see a lot of these teams that they're really stressed. And I think that social workers are uniquely prepared, and we talk about coaches and navigators, they're uniquely prepared to bring evidence-based approaches and teach those to the teams at all levels, from the top of the food chain to the entry-level volunteer people to the receptionists at the front desk. And those behavior change models and these self-awareness models, the kind of, in fairness, like there's a lot of movement now toward mindfulness. And I was in this anecdotal, but I was interviewing somebody, and they said, I don't want Pachelbel's canon or a deep relaxation exercise. I want 15 extra minutes. You know, and I think that, you know, we have to be aware of that as well. And those things won't change, but I do think that huddles are a way to address that. I was with the Donlin study, we were in Colorado, and first thing in the morning we flew out there, we got there to a team, and they sat around and spent 20 minutes talking about what they did over the weekend. It's that relationship building. Now, how many people have that luxury to do that? And they recreate with each other outside of work, which is pretty extraordinary as well. Maybe it's a Denver thing, I don't know. Anybody from Denver?
Denver is a pretty fun place. So let's move. I want to move for the last few minutes before we open it up for audience Q&A to the question of policy. We are, after all, here in Washington, D.C. And Andrew, you know, you talked about one particular issue in the Medicare payment model, and it's kind of amazing that, you know, you mentioned that it was finally implemented in 2014. That was 3 years ago.
Yeah.
So what are some of the policy options to improve upon some of the issues we've been talking about, whether it be access, training, integrated care? You mentioned delivery system. Let's talk about the policy options and some of the different programs that are in place to do that.
Yes. So like everything else that happens in healthcare, we're behind. Behavioral health is behind, and we were behind on electronic medical records. Our providers, including Mohini's members, were left out of the High-Tech Act and the meaningful use payments that began in 2009 and 2010. It was a error of the staff, the Democratic staff, Mark. Not that it was in the stimulus package, and they referenced a section of the Public Health Service Act that excluded community mental health centers and psychiatric hospitals. So that left us behind with the development of electronic medical records. In addition, we have an obscure federal regulation that was promulgated during the Nixon administration called 42 CFR Part 2. I could spend another hour explaining what this is, but it's basically beyond. And again, long before HIPAA, there was a scheme for consent for sharing of medical records that apply only to substance abuse treatment records, and it is a major barrier to getting an integrated electronic medical records, because behavioral health records end up getting excluded from that because you don't have that separate higher level of consent. And it's a big problem. We have legislation in Congress to fix it, and we're hoping it will advance this year.
When you specifically talk about the behavioral health workforce and the safety net, one of the huge inhibitors right now is pay. these organizations are not able to pay the behavioral health workforce very well. This is deeply connected to the reimbursement that the organizations receive for billable services. One of the ways in which we're trying to sort of shift that dynamic is by establishing a new kind of entity in the safety net called Certified Community Behavioral Health Clinics. And these organizations, the idea is that similar to FQHCs, receive prospective payment. So they're paid for actual costs of services provided. Right now, this program is a demonstration program via Medicaid. It exists in 8 states, and there's about 70 organizations that are participating. And so imagine the idea, we estimate that in traditional form of payment, for every dollar our members spend on someone that is a Medicaid beneficiary, they're only paid 70 cents. So day after day, if you're underpaid again and again, that means a lot of scary things for you as a nonprofit organization. So then suddenly, under Certified Community Behavioral Health Clinics, when you're asked to define what the costs of the services are that you're providing, not to make a profit, but simply to cover the cost of the front desk staff person confirming the appointment, having the patient come in, the cost of the rent of the space, and the cost of the electronic health record, and all of the wraparound supports that help make a behavioral health person, a professional, successful with their patient. If those costs are covered, that suddenly means that maybe these organizations can pay their staff a little bit better. We're already starting to see some anecdotal evidence of this making a difference. This program just started. They received their first new kind of payment this summer. We heard a story of one of these entities that's located in a very rural community that's had an open child psychiatry position for 6.5 years and was finally able to hire a child psychiatrist. And there's no child psychiatrist for 150 miles around this agency. So all of a sudden, if we can shift and remember that these organizations are a critical component of the safety net and use policy to drive resources in a way that represents their costs, we can try to start to shift some things about the quality of care that the patients are receiving and, connected to the focus of this panel, make it so that this is an inviting employer of choice for the behavioral health workforce.
Thank you. Did you have
too quick?
Yeah, go ahead.
Ironically, the people with the most touch get the least pay. That's always been the way. We've got to look at that. Robin Stone was here. She'd be screaming about that, I'm sure. And she's right, in my opinion. And the other thing is that we'll follow the money. In addition to that, we also have, and I think we've learned from industry, we can change organizations. There are technologies by which organizations can be changed, and that includes healthcare organizations. We can do it.
Great, thank you. Well, I would like at this point to open it up to audience questions. I have your hands went up first in the back. So we'll bring the mic to the two of you, and then I think I saw some. Okay, great.
Thank you. Andrew Kessler, representing the ICRC, the International Substance Abuse Counselors. Question for whoever wants to field it. Behavioral health in and of itself is a tricky phrase. It's kind of all-encompassing. It includes a lot of different areas, and just like other areas of healthcare, there are specialties. For example, an oncologist may do cancer, but there are those oncologists who may specialize in breast cancer or colon cancer or brain cancer. Also within behavioral health, there might be professionals who specialize in mental health or substance use disorders or other issues. And then there's the need that the panel mentioned for training primary care in behavioral health. So with limited resources, how do we address all three of those issues in terms of what should our priorities be for training and recruitment and retention in terms of primary care, training them to be better versed in behavioral health, the larger world of the behavioral health catch-all, and the specialists within behavioral health, because there's a lot of comorbidity, as Andrew mentioned, and a lot of co-occurring disorders within that. So how do we address all three of those issues with our limited resources?
Couldn't you throw us an easy question to start us off? And this is an endless debate, and I think depending on sort of what your angle is, you're going to pick different priorities here. From my perspective, this is a sort of dual focus of thinking through for folks that are most severely ill. We need to make sure their workforce that they're most likely interacting with, which will typically be in the specialty safety net system, we need to make sure that they have access to continuing education opportunities to keep them up to speed with the latest in technology and evidence-based clinical practices, and how do you do team-based care and other things. And and then when you think about folks that are more on the mild and moderate side, we have to really think differently about healthcare. This is about how do we keep healthy people as well as possible for as long as possible, and readjusting our mindset so we can think about nutritional interventions, mindfulness, other kinds of alternative practices, and making sure the workforce is aware of those non-traditional models, I think is just very important.
Anyone else want to? All right, your question.
Hi, my name's Patty Absher. I work for the Public Health Foundation. I'm the director of the Train Learning Network. So I have a PhD in epidemiology, and I started as a master's in social work. There are a lot of integrated programs for physicians going into Masters of Public Health, but there aren't for MSWs or doctors of social work. There's not that crossover. Is there any sort of glimmering hope that that might be one of the bridges regarding these teams? Is that not only is a social worker, the MSW, but also has possibly that MPH?
In fact, there are quite a few joint or dual MSW MPH programs. My school offers PhD social work students the opportunity to get the same 1-year MPH that physicians take the 3rd year off for to go get an MPH. More than ever before, there is a lot of interprofessional investment in interprofessional education. The CSWE, Dr. Spence Coffey, was instrumental in getting social work brought into the IPEC. So I think that the Affordable Care Act really opened the floodgates on that, and it's really the key to integrated care is to have everything in place. The problem is paying for it.
Thank you. Susan, and then...
I'm Susan Hildebrandt with Leading Age, and I work actually with Robin Stone.
Did I represent her well?
You did, and she would be screaming. You're absolutely right. My question is this. I see a lot of similarities between behavioral health being disintegrated from the rest of medical care. Mm-hmm. And the same thing seems to be true in long-term care. It's disintegrated from the remainder of mental health, despite the fact that it also has a social component. People are living in our communities as opposed to being in hospitals. I am wondering if you have any suggestions for lessons learned in terms of integrating mental health with the remainder of the medical world, things that we can think about within the aging services field.
One thought that comes to mind for me is the role of peers and people with lived experience in the behavioral health space. I think has truly revolutionized day-to-day how the workforce thinks about this concept of integration. In the behavioral health community, it sort of developed in silos, but between mental health and addictions. But there is a flourishing sort of level of the workforce of individuals who choose to bring their lived experience with a mental health or substance use issue to their professional lives and share of that experience with others in the hopes that it helps to raise them as they're struggling with behavioral health issues themselves. In many cases, although not all, there's Medicaid reimbursement available in 30 plus states now for these individuals, and we're still learning as a field how to fully integrate them into different kinds of treatment settings. But as I talk to these folks all the time, and there's many organizations that stay connected to peer leaders around the country, they talk about the importance of this stuff. day in and day out. They just fight the good fight and talk about how what they've experienced with the fragmentation in the system, and talk through for everybody else, hey, these sort of traditional, these historical silos you've created that's limiting communication, that's limiting sort of partnerships, it's all just foolishness from their perspective. They're an integrated individual, and that we're all losing out for not offering integrated services. And so I think that on the ground in communities, they serve an incredibly powerful role in shifting how we all think about this.
Thanks. And before I go to the gentleman's question, and then you had a question, then I saw the lady over there, and that will be our final question. But I want to just quickly kind of push on this point of, we heard about social determinants of health in the first panel. Peter, you brought up, of course, the non-medical needs, dating back to at least 1915, this recognition. And I just want to ask you to kind of briefly comment, obviously non-medical needs span much more than behavioral health, from, whether it be nutrition or housing or that kind of stuff. But do you feel like the behavioral health professions community is the one that's touching, and dealing with those non-medical issues more? Like, where's the intersection? Where is it? Where is it? Are we conflating the two too much? Talk about that a little bit.
Real quickly, it seems that everything's getting dumped into primary care. Everything. It's like, send to primary care. We just had a dissertation, somebody, fear of cancer recurrence, cancer survivors. They can't be followed in cancer centers anymore because it's a chronic disease. So those are the kinds of issues that land there. Is that a medical issue, or is that a psychological issue? It's really a psychosocial issue, and it really affects the person in the community and the environment that they live in. So I think it's really this notion of this understanding the person in the environment. And that's where I think a lot of integrated healthcare systems are using social workers to sort of lead the behavioral health aspect of their programming. And they're very well positioned to do that. And as I said earlier, up and down. There's more of it. I'll defer to my colleagues.
So there's no more powerful social determinant of health for people with mental illness than unstable housing. It obliterates everything else. And so here, the difficulty we run into is the public mental health system cannot solve that problem. That was the problem to begin with when we had 500,000 people in state psychiatric hospitals. They were both simultaneously the care provider and the landlord, and there are inherent conflicts there, right? When you're the landlord, it's a very different obligation than being the care provider. And the issue when someone's not adhering to treatment is to throw them out of their housing and make them homeless. It's not going to make the situation any better. So we are really struggling with this and getting the affordable housing system to serve our population.
And where we very commonly experience deep pain in communities are these folks ending up in jails.
Yes.
As the way in which they're housed, warehoused really, because there's no place for them to go that's safe. And we all need someplace we can put our head down at night. And ignoring this and thinking it's just going to go away, we're all paying for it. They're ending up in ERs and they're ending up in jails and prisons.
I spend a third of my time working on housing. When I leave here today, I'm going actually to meet with the officer on the Senate Appropriations Committee to talk about the HUD budget.
And we in medicine has to stop seeing the patient and the clinic contact and really see the patient in the environment. And I think that's happening. And the other great proponent of behavioral health is law enforcement, because they're the ones that take the front line on it.
Absolutely.
Yeah, so they're part of the workforce too. Thank you. All right, we're going to take two questions over here, and then the young lady over there. So the gentleman first. Sorry. yeah, go ahead. Oh, you guys switched.
Anyway, should I continue?
Yeah, go ahead.
Rick Blake, the Institute for Family Health. We're a network, I said before, of federally qualified health centers in New York. And everything you just said applies to the Institute. So, I mean, the connection between connecting, let's say, HIV patients, because 20% of our patient population HIV, AIDS positive. So all of the connections, housing, wow. I mean, you can see one person one day and one person the next day, and bang, you're seeing the same person twice and the same beat. So I'm saying this: how do we underlaw our network of federally qualified health centers to connect this explosion And it is an explosion, particularly in New York and maybe Boston. This explosion of a Medicaid patient population with comorbidities, which include mental health and all of these therapies. Because if they have mental health issues, they ain't taking their drug medicine, so that's just it.
That treatment failure is really, really expensive, right? And horrific outcomes.
Agreed. I mean, it's, your points are really valid. There's so many research studies that indicate when someone is sort of not in active treatment for their mental health issue and they have other physical health problems and medications that they should be on, they're not going to be adherent to their physical health regimen unless their mental health issues are addressed as well. There's the federal government has attempted to really invest in FQHCs through behavioral health expansion grants that have been issued over the last few years. Not all FQs have done that. Many have, and I think that that's been helpful. We know from our experience that many of those organizations are partnering with specialty behavioral health, particularly for the patient population that's their behavioral health issues are so deeply chronic that it's beyond what the workflow and scope is of an FQHC. There are positive movements happening with this, but it's going to take time.
Let me, I want to take the next two questions, I promise, even though we're running out of time, so go ahead. Thank you for your patience.
Hi, my name is Beth Pointer. I'm with AFSCME, a bunch of letters that mean I'm with the labor organization that represents workers in behavioral health. I spend a lot of my time talking with workers in the community mental health system, and you talked about how they're low paid. I'm here to rant about that, but mostly we talk a lot about turnover, and in community mental health, the turnover is incredible. They're serving the nation's neediest, and they've got the highest caseloads of anyone in behavioral health. Most of our workers talk about caseloads over 100 people deep. That turnover has got a great impact on client care. And so my question to you all is this vicious cycle of turnover, and how do we have trauma-informed care that takes those clients into consideration and how that turnover might affect their care? But are there studies that are being done on how this turnover affects wait times and affects client care outcomes? And then also, are there policies? Like, we see nurse-to-patient ratios on the physical health side. Are there policies like that people are thinking about for the behavioral health side? Thanks for your time.
I know in practice there are some, I don't want to use such a strong word as standards because they're not validated in the same way, but there's sort of promising practices around what client ratios should be for different levels of staff, and we see a lot of that sharing happening. We have a big member listserv, and the members are sort of sharing that information all of the time via email. I mean, the trouble is that it isn't that these organizations don't think the caseload should be lower, or they don't understand where their staff are coming from with this. This is connected to how these organizations are paid. And until we shift that and think through focusing on value instead of volume, we're not going to see these numbers change. We also see in states where there are pilots focused on value that they're being much more creative and thinking about how they use different levels of staff in community mental health to try to segment patients based on what their current health needs are, and making sure they're working with sort of the level of the workforce that makes the most sense for them. I also think, again, we have to focus on the opportunities with technology. I've heard of some for-profit technology companies that are backed by private equity that are thinking through, for this level of staff you're talking about, they don't really have any training in how to exist in this setting. They don't have the tactical skills to succeed, which is going to lead to burnout and them quitting out of fatigue because they're also low paid and they can't pay for their meals and their rent.
I just got to go on. You're right. Just please understand, the VA, unfortunately in behavioral health, the VA is driving a lot of this, and it's not necessarily a bad thing. If you are a master's level clinical social worker working at one of Mohini's members, you can double or triple your salary by walking across the street to the VA because Congress is throwing money at this problem. They don't want to put up with wait times for mental health visits at the VA. So it's not a bad thing, and I'm certainly not recommending, believe me, this is a serious issue that the country's grappling with in terms of, a decade of two wars, and we're going to have to deal with it. But the fact of the matter is, for a good reason, Mohini's members are really struggling to hold on to clinical staff.
Mm-hmm.
In terms of studies, Paul Osterman's book, Who Will Care for Us, just came out. It's a good summary of the evidence in this area, and there's a lot of it.
We can link to that on the Alliance website. Thank you. Your question, and that'll be the last question. Thank you.
Yes, thank you very much. Setting aside the issues of crossing jurisdictions, where are the benefits of telemedicine in the area of behavioral health? Because I haven't heard anyone mention that yet. I'm
glad you asked that because that's also going to be a perfect segue into our next talk.
It's huge, yeah. Very important.
Well said.
We've advanced quite a bit in our practices around telehealth, which has been really fabulous. So in the beginning, it's been about, okay, well, we need to make sure there's the broadband and the privacy issues are addressed. And we're becoming much more sophisticated now, thinking about, well, what are the skills that individual, whether it's a physician or a social worker or a nurse, whatever, who's offering the telehealth services, they need to train to have a specific skill set and to have a certain sort of style in their professionalism that lend itself to technology-based interventions. And then similarly, whatever the location is that the individual is in, whether that's in their home or in a clinic or some other, a library or whatever community-based organization, that setup has to be done in a way that allows for a safe environment for the person to talk about some really difficult things. So there's been great advancements in this space that make this more of a realistic option.
Thank you. We are out of time. We're past time. Thank you. Thank you to the panel. Really appreciate all of your comments. Thank you. Great.